Hello and welcome. According to the World Health Organization, the COVID-19 outbreak is gaining pace in Africa, with incidence cases and fatalities rapidly rising each week. The pandemic is still driven by the top 5 reporting countries: South Africa, Nigeria, Algeria, Ghana, and Cameroon, which account for 70% of all cases and 74% of all deaths. The disease is also expanding widely to smaller urban centers and rural communities, but despite rising cases, many countries continue to ease confinement measures imposed earlier. The WHO Health Emergencies Program, which focuses on public health emergencies, is currently monitoring 114 events or so in Africa. These include disease outbreaks like COVID-19, Ebola, measles, Lassa fever, cholera, malaria, yellow fever, plus other emergencies and crises like the complex humanitarian crisis in northeast Nigeria. With an estimated 7.7 million people in need of humanitarian assistance in that region, response to the COVID-19 outbreak is taking priority, along with the continued need for response to other infectious disease outbreaks and other health priorities, such as malnutrition and sexual health and reproductive health services. This has been complicated by an upsurge in attacks by terrorist groups in the area. Government has been called upon to ensure that the COVID-19 response activity complements and does not disrupt the necessary responses to other infectious disease outbreaks. On View from the Top today, I'll be speaking with the former Provost of the College of Medicine and current Deputy Vice Chancellor, University of Lagos, Professor Folasade Ogunsola. Professor Ogunsola is a professor of clinical microbiology. Her research and interest work has centered around diagnosis and prevention of infectious diseases, antibiotic resistance. She was a founding member of the Nigerian Society for Infection Control and has assisted in setting up infection control programs in institutions around the country. It's a very long CV, but I've tried to abridge it. So here's a few more things I'd like you to know about Professor Ogunsola. Professor Ogunsola, thank you for joining us.
Thank you very much.
With Ebola in 2014, we were dealing with 2 pandemics, the pandemic of the disease itself and the pandemic of fear. But with COVID-19, which is said to be a more insidious disease, there's almost a nonchalance that I sense from a majority of the people. How do you explain that?
I think part of it had to do with the television. People were expecting to see what they saw in Europe. And when that didn't happen, it almost became a non-event. I mean, I've read people on social media saying things like it's a hoax. And then part of it also was that it came in like Ebola did amongst, should I say, those who can travel, the more elite. So it just did not trickle down. And we were fortunate because some of the measures we took initially helped to slow it down. So we didn't see what we saw on TV, which was what we were anticipating. So by the time we started to see a few cases, it was an anticlimax. So people, I mean, somebody said, isn't it the same COVID that went to Europe? What is happening in Africa? So I think a few people, well, I think I'm being generous, I think a lot of people don't really believe that it's here. And then there's a lot of misinformation. Some believe that there's something that we have that's preventing us from getting it. But what I think is that it landed softly and probably had not taken ground for a long time.
Speaking of something, I'm willing to bet that a lot more people have died of malaria than they have of COVID-19 since this pandemic hit. Am I right or am I wrong?
I think you're wrong.
Okay, so malaria is almost...
It's not that malaria is gone. Malaria tends to kill more the young. because most of us that live in Nigeria, there's what you call a holo-endemic area. By the time we're of a certain age, we're relatively new. So malaria tends to devastate at younger ages. And unfortunately, anybody with a fever says I have malaria. So I think some diagnosis of so-called dying of malaria, maybe dying of COVID. So I'm sure we're getting some people dead in the community that are dying of, because everything in fever is called malaria here.
So it might as well be COVID, and we don't know.
I think we are seeing a lot more, that there may be a lot more COVID in the community.
Than is being reported.
Well, than we know. The health, that people, practitioners know, because we can only know what we've seen or what has been reported. So, and COVID is insidious. It comes in like fever, body pain. Yeah, some people don't even cough, so they may not even think COVID. And so it's if you're tested, or if we see some of the more characteristic signs and symptoms, and we know, then we can say this is COVID.
Experts like yourself have stressed that every country's best defense against the pandemic is to find, isolate, test, and care for every case, and to trace and quarantine every contact. But to improve outcomes in potential cases and to break the chains of transmission, are we doing enough?
No, but I think there are two areas. There's personal responsibility, which is probably the most important, and then there's also the area of government. Unfortunately, I don't think we have a cohesive and coordinated response. States are doing it by themselves, essentially. And what they're doing depends on the governor. So there's some states that are in denial, there are states that are active, but till we all do it in one way and take it as seriously as it should be taken, I don't think we'll do well. That's one. The second part is the personal responsibility. I always say the virus walks with the people. The virus does not just hang around somewhere in a corner. It's in people. And it can only spread where people go and how people behave. And it comes out of your mouth, it comes out of your nose. So if we do, and it tends to travel a distance. The closer you are to a person, the higher the concentration. The further you are away, the less the concentration. So open air is good. But a lot of people are not wearing masks. Those who are wearing masks are wearing it under their nose and their mouth. Or they're wearing it and then when they want to talk, they take it off and talk, which is exactly the time the virus comes out. So there is a lot of irresponsibility, I use that word. People are not using their masks, especially in crowded places. People are not socially distancing. You could actually talk to people, but just keep your distance. Preferably don't talk directly to them, because a lot of it comes out in close contact. And then the contamination from what comes out of your mouth is what contaminates the environment and your hands. Then do that cleaning. So if you touch something, clean your hands. That way you cut down that transmission. So if there are no people, there's no COVID. It's that simple. But our people are acting as though there's no COVID.
But then there isn't as much testing, is there?
We don't have enough yet, but it's improving.
It seems almost certain that the numbers are underreported.
Oh, clearly. The reason I use the word underreported is that underreported suggests that it has been tested but not reported.
Correct.
It's under-tested that we
it's
have. But everything that's tested is reported.
Correct. Okay, yeah, makes sense.
Yes. So yes, I think we don't have we have not adequately captured the numbers.
Like we don't have a vaccine for HIV yet. You're an expert in that area. What if we never get a vaccine for this? Some say that this is not going to go away, and we just have to learn to live with the virus. There's still so much we don't know about it, right?
Okay, even if we don't get a vaccine for it, there will get to a time when most people will have been exposed, and the rampant weights going around will reduce, because if I'm exposed and I have antibodies, we don't yet know how long it takes. But if we just go by the way the immune system works, there will be some protection because you have been exposed before. We hope there are two things we pray for: that the immunity we get lasts long enough. But whether it lasts long enough or not, if you've been exposed, it does create some sort of, it may take off the edge from the seriousness of the disease you get. That's one. But the most important thing that we hope is that the virus does not mutate rapidly in such a way that it makes it useless, your immunity. So far, it appears to be a lot more stable than we. There will always be mutations in viruses, but it does not seem to be mutating in the areas where it matters. So, if there's no vaccine, then we're in for a long walk, but gradually, we just start seeing fewer cases as more people get ill and recover.
Apart from COVID-19, there are other insidious diseases that should be on the country's radar but aren't. For example, there are reports that measles cases are increasing, possibly because of the interruption of immunization activities by this COVID-19 response. How do we keep all the balls in the air without dropping any? And what are the potential costs of losing sight of these other diseases?
Whew. I wish I had a very great answer. We have a lot of problems. And certainly, with all these balls in the air, we're already handicapped. The country, as a general rule, does not take health seriously. We don't budget for health. I don't think we accord health the greatest priority. And for me, in infectious diseases, in a way, I think COVID is a wake-up call. And I say that because for as long as we don't budget and pay attention to health, our balls are going to fall. They're just going to drop. Because we don't address health, we don't have enough good hospitals that can handle the deluge that's coming. We don't have the human resources, not because we don't have good people, but they're overwhelmed on the normal day-to-day and demoralized. But the good thing with COVID is we're all here.
If there's any good thing about it.
That's the good thing. The government officials can't travel, so they have to use the healthcare system they've built. The organized private sector can't travel, so they have to use the healthcare they've ignored and left to government. The rich cannot travel, so they have to use this healthcare that we've all acted as though it didn't matter. Because any good country, it's your public health system that can really take care of the majority of the people, both rich and poor, not the private sector. So till we recognize that we need to adopt our public health systems and build them up and stop leaving it to a government that's not interested, we're not getting anywhere. So COVID is holding us in, and I think we'll be in for a long time because our epidemic isn't going away, and we won't be one of the first countries that people will allow to come. We won't.
Protect the NHS was not just a slogan, but apparently one of the tactics employed by the UK government in this fight. As you said, the pandemic has exposed the vulnerability in Nigeria's health sector at all levels. What can we learn from, say, the UK, for example, how it handled this?
Okay, if you notice, when Boris Johnson was ill, he went to one of their teaching hospitals.
Correct.
Because a teaching hospital is supposed to be the apex. It's not the private sector. Because that's where you will get good care at affordable prices. And you will have the concentration of your specialists. Let's face it, even in the private sector, most of the specialists that work there come from the public sector, but they have the tools to work. So you make your public sector the cream of your hospitals. So, and it's not something you can do during a response. The response is an emergency. You cannot build the broken during the response, but it might start us off. That's one. Two, one of the things that the NHS has developed what I call a competency muscle. Things like the infection control that is required to stop transmission with the PPEs, they're there. And still there, COVID overwhelmed because nobody plans for the deluge of patients that need emergency care and critical care. This volume, there's no country that can be ready for it. But they had it. Then we also had backing that a manufacturing, you have a manufacturing sector that can do certain things. Here in Nigeria, we've outsourced everything. I mean, we have not invested in what we have. Part of our problem is that we see America and we think if you start at home, it can never be as elegant. It can be functional. Mm-hmm. If we don't invest in using what we make, then they're not going to grow. So we ourselves just sort of break down while wanting the best without working for it. So what COVID has done, and I think what we can learn from the NHS, that hopefully we will all wake up and start to invest in our public sector. People will tell me, oh, but it's government, will they allow it? I said, yes, you adopt a place. Go there and just say, you know what, we're taking over these wards, we will do it. People are doing it. We just don't have enough people doing it. And as we become more involved, then we really can talk to government. But we're all letting it as though it doesn't concern us. But it does. And COVID has shown that for as long as we neglect education, health, we're not going anywhere. We can never be a developed country till we do that. And we're also seeing the rise of racism. And I keep saying it, till Nigeria gets its act together, the black man's lot will always show us what you have. We're the largest black country. And what have we shown the world? That we're parasites? I mean, that's the way I look at it. Let's do our homework. I mean, I hope COVID wakes us on. I'm not yet I think some governments have woken up, but some governments have not. And to think that during this epidemic, the health budget was cut again, I mean, does that show seriousness? It doesn't.
The humanitarian crisis in northeast Nigeria continues, and the COVID outbreak is ongoing in these conflict-affected areas as well. While the reported numbers have decreased in Adamawa and Yobe, there was a significant upsurge in the number of cases in Borno. In Borno State alone, there are about 51 high-density IDP camps. Are we sitting on a keg of gunpowder in the northeast Nigeria?
Yes. Yes, there is no gainsaying that. My fear, though, is that many people just don't get to where they are counted, and that many will die at home, and people are not counting them. And in the IDPs, I don't know how well we're attributing COVID to some of the conditions that are killing people. So if somebody had diabetes and dies, we'll just say he had diabetes, but what was the exact cause of death? We have asthmatics who may die, but COVID may be the one that pushed them over the edge. And if we didn't diagnose it, we won't know. So I think we're going to see what we're not looking for, hoping it won't happen, is that if we start to have an excess of death in any area, we should think COVID. Because COVID is now community spread. So one won't know where one got it, and we're just going to be seeing people die. I'm afraid for the IDP camps, really afraid.
Health worker infections have also been reported all over the country, which brings me to biosecurity and biosafety. How can we make these issues widely understood and appreciated?
The health worker infections happen in 2 places, or should I say 3 places, because a lot of the people working in COVID are in public sector, but because it's community-based now, we're going to be getting people who go to clinics and hospitals in the private sector, purportedly not COVID, but COVID, transmitting COVID. And healthcare workers, if they're not careful and wearing their masks, I use the word masks particularly because that's the most important of all the PPE, and doing their hand hygiene, will get it. And I say that because especially in the early stages, they were not working in the public sector because they thought that was where the COVID was, and were careless when they move out into the private sector, thinking there's no COVID there, and got infected, then come back and infect their colleagues in the public sector.
And some of their patients, possibly.
Possibly, but well, it's possible. Anything is possible. I think everybody is wisening up. I'm hoping to see, because what I've found with all infectious disease epidemics, in the early stages, healthcare workers get infected very quickly because they tend to take the infection prevention and control measures with a little bit of levity and don't think they're in a particular situation that they need to use it, whereas you're supposed to use it all the time.
They don't feel as vulnerable as the rest of us.
They don't feel as vulnerable at the early stages. So when a few of them get infected, everybody sits up and then suddenly healthcare worker infections start to go down. So the other part of it is getting it in the community, because they live in the community, and that's where your guard is down. What we've seen is the people actually working in the isolation centers themselves that are seeing the patients, many of them are not getting it because they're protected. It's when they get out of it with colleagues and they're all talking and nobody's socially distancing or doing what they need to do, many get it. So we can't ascribe what percentage, but we do have some that we do know that healthcare workers infected themselves. Some were infected in the community, a few within the hospital. But I think it is becoming, everybody's getting more careful. So I'm expecting that to go down. But
do you have an interest in the application of infection control principles for the prevention of transmission in low resource settings?
That's what I love. I've been doing that since 1998, or 1995, 1998, when it was not, should I say, fashionable. And I use it because infection prevention and control, really for it to be effective, has to be integrated into healthcare. It's a quality standard. You should, in every hospital, you should be there with all the documentations and so on to ensure that any patient that comes into a hospital lives without an added infection. Because if you think about it, the hospital is the place where you have a melting pot of the sick. Everybody there with something. So you come with your own, you give it out to somebody else. If things are not done to prevent the spread of microorganisms. Right now in the country, and in many African countries, it is treated as a public health response. So that immediately after that response, we go back to sleep without actually putting in place the measures to ensure that it's happening all the time. So every time there's a response, they start, let's teach them infection control. Then because healthcare workers are not used to infection prevention and control on a day-to-day basis, first of all, you get fear. You will see that you did not have that kind of fear in England because it is a part of your healthcare system. You do it every day. If you're coughing, there's a way they handle it. Because it's the IPC, the infection prevention and control, is tailored to the routes of transmission. So it doesn't matter what the organism is. I say it's like dealing with thieves. No matter how malevolent and how well armed a thief is, if he cannot enter your house, he cannot steal your goods. So IPC is like the fortress that keeps the house safe. Once you're safe, doesn't matter what's coming. And so and because many times people think of what people are doing elsewhere. Oh, they did it like this. It's irrelevant. What matters is what are they doing? What is the goal you want to achieve? So whether you can achieve it with a lot of money or achieve it with a little money, as long as you can achieve it, which is prevent that organism from going from someone who's infected to a susceptible host, you've achieved it. So what I've worked on over time is how do we contextualize, how do we make all these principles within what we can do. People talk about, oh, they do this in America, I think that's really not what matters. We may not do it as elegantly, but as long as we achieve the goal, which is to prevent transmission of organisms, then we'll be fine. And that's what we try to do. Part of our problem now is we build as though we're in Europe. We have a very hot country, and we build up with very small windows. That doesn't work.
We're talking about isolation centers now.
Even the isolation centers, one of the things we have to deal with is, again, which we have, that part of it is maybe a little hard for us to do. They're hot. We have these huge tents. Air conditioners are not the best in terms of maintaining ventilation, good ventilation, in terms of changing airs, because it extracts and circulates the same air within the space. But, you know, I was really impressed when we got to Unicom. I think it's the Unicom one. Because we're trying to get rid of the AC effect of circulating air within that space, they created a second ceiling, and pumped all the AC into the space, cooling the air above, which cooled the space beneath without creating the turbulence. So we try to find solutions that help. Now that's not the ideal, that's not a very good one, but it just shows you the kind of things we can do. One of the easiest ones you can talk about is in hand hygiene. I mean, I was amazed. People have the no touch using the bucket and bowl, you know, the bucket and what we call the tippy taps. What's important is water gets to your hands. So you have the bucket, you have something that tips it over, so you don't touch it at all. They also had a wooden lever that got you the soap without you touching anything. Very crude, but you get a no-touch technique. You have water, you have soap, everything in your hands. And this can be deployed in a village. We can always make it more elegant, and that's where development comes. Somebody starts a crude one, somebody builds on it. And if we can just get into that habit of building on things, then we will just find that things get, you know, we'll get a lot further and have a lot more respect.
Finally, what are your thoughts on the Infectious Diseases Bill 2020?
I think that was another cut and paste. The infectious disease bill that came out. I think it was one of those things that were not well thought out. It gave too much power to the NCDC. Now, if you have a sensible person there, there might be no problem. Because when you have power, and you understand that power is something you don't use, but it gives so much room for abuse. You can't just take anybody's thing and take over their rights. So it was trying to solve a problem that during the public health, you have to act in the best interest, but you cannot give anybody power that cannot be pulled back. And that was what we saw about that particular bill.
Professor Folasade, Ogunsola, we thank you for your time.
Thank you very much. It was a pleasure talking with you.
And we thank you for watching. Please join us next time when we bring the program on air. But between now and then, let's continue this conversation online. Do tweet me your thoughts. And please join us next time. Bye-bye for now.